Thank you very much, Dr. Miyazaki. That was very nicely done. My talk here is about why we should not care about gadolinium retention. And understand, I'm a radiologist, so it's not just about MRA, where yes, sometimes we can use non-contrast techniques. I mean, gadolinium is something that is unbelievably vital to diagnostics. This is me getting excited about my flight in my new glider. And this is me getting excited about gadolinium retention. So you know which side I'm on here. I think let's just take a minute to just separate NSF from gadolinium retention. I mean, they're both they're both gadolinium related phenomena, and both are real. I mean, retention, I'm not going to say it doesn't exist. Our bodies are reservoirs for all kinds of heavy metals, including gadolinium. We've known about that since 1984 at least. NSF, however, is a real disease, and it has serious morbidity and mortality. It was kind of discovered around 2006 that the association with gadolinium in the appropriate clinical milieu, meaning typically renal failure, and we've essentially eliminated this by understanding and avoiding its associations. Almost all of the NSF came from 3 different contrast agents that are all considered group 1 right now. I've written their generic names up there, or their product names rather, and pretty much all are contraindicated for patients with low GFRs now. As a matter of fact, they've been withdrawn as part of linear agents from the EU since 2018, and their use in the US, I think, is really waning. The group 2 agents, which include the macrocyclics as well as the linear agent multihance, are all considered safer, and there are few, if any, unconfounded cases of NSF with these agents. That's what I could find in the literature there. So for all intents and purposes, we know how to get rid of NSF. NSF is related to gadolinium. It is a problem in certain circumstances. So we don't give group 1 agents to at-risk patients. And group 2 agents, a lot of people are still worried about them, but there have been actually a lot of nice trials done recently that are both retrospective or prospective, following up out to 24 months, looking at dermatologic, histopathological assessment of any suspected lesions. Here are some of the numbers of this. So multihance over 2,000, Dotarem 300, Gadavist over 900. These are all at-risk patients with either on dialysis or high-grade renal insufficiency, Prohance and Eavist, and there have been no cases of NSF. Sorry about that. My hospital has recently gone to a GFR floor of 15 before we get concerned about giving any group 2 agent. So if you look at PubMed publications, in the orange there are NSF publications, which are dropping. And in the blue are gadolinium retention publications, which are increasing. So let's talk about that a little bit. So we've known it's been around for a while. We know it occurs in all tissues with all agents. This is some work by Tweedle and Wedeking looking at mouse retention. And time is on the bottom and amount of retention is on the y-axis. I don't think my light works much anymore. But at any rate, depending on what the chelate is here, Omniscan versus Magnavist versus Dotarem versus Prohance, there are different amounts of retention, and generally there seems to be more retention with the linear agents. But these are quite measurable, and they are around for a while, and we've known that. The brain gets all the hype because that's where it was discovered that, hey, we can see T1 brightness in the deep gray nuclei in the brain, and it can correlate with the amount of gadolinium injections someone's had, and also histopathologically it correlates with gadolinium seen in autopsy studies. But actually it turns out the brain is not anywhere near the largest reservoir of gadolinium. It's probably the bone. And it's well known that most of the gadolinium that is retained in the body ends up in the bone. And different studies show different things, but for instance, Gibby and White showed that 1 to 2% of Omniscan is in your bone at 4 days. And another study really shows that once it's there for 8 years or maybe even indefinitely. So this has been happening for a while. Just to reiterate, NSF is the only serious condition, and retention happens, but how do we compare kind of the benefit to risk ratio of using gadolinium? Because I think there's some hysteria out there that, oh, we should stop using gadolinium. As I said, as a radiologist, that's almost a ridiculous question to say, how do we compare the risk-benefit ratio of using gadolinium? Because there are vast areas where, MR and MR with contrast is by far the best diagnostic test to do, and there's no question that this saves lives and improves outcomes and improves diagnoses, et cetera, helps us arrive at the best treatment. And MR with contrast really is the best test, not always, but many, many places, particularly central nervous system. Neuroradiologists will tell you this. I'm an abdominal imager myself, so liver and abdominal organs, particularly oncology, pediatric, very important for breast screening. It's the gold standard for myocardial viability, inflammatory diseases of the musculoskeletal system, perfusion, both in the CNS and cardiac, and an important alternative for patients that might have renal impairment or iodine allergies, or they're perhaps young and we don't want to expose them to radiation, particularly over and over again. So when we talk about risk, we've got to talk about real and proven risk. We've got to talk about unknown risk, and we've got to talk about perceived risk. And gadolinium retention, I think, is mainly a perceived risk at this point. Let's just ponder some numbers here. There have been somewhere on the order of 450 million doses of gadolinium given worldwide since 1988, when it was first introduced. We have more than 30 years experience. We do about 10 million gadolinium injections per year in the US alone. And there is no, and I repeat, no scientifically established associated adverse health effect with gadolinium retention. As I said, it was first seen and brought to notoriety by Dr. Kanda in 2014, but there have been a number of histopathological, both human and animal studies trying to find some signs of some toxicity or association with any kind of pathologic outcome, and nobody has found anything. Here's a couple of examples. Welk looked at almost 250,000 patients who got gadolinium agents over 10 years and looked at the outcome of Parkinsonism. And if, I'm not really a neuro person, but Kevin DeMarco can probably set me straight here, but where you would expect to have problems if this agent is in the deep gray nuclei is cerebellar type symptoms and Parkinsonism type symptoms. And saw no difference in this large cohort of patients. As a matter of fact, it wasn't statistically significantly different, but you actually had a lower rate if you'd gotten more gadolinium. So therefore, gadolinium is useful to prevent Parkinson's, right? No, that's not what that says. McDonald, a presentation at RSNA, looked at 1,315 Omniscan exposed patients, doing all kinds of Z-score, memory, language, visual, dementia scores, no difference. Kokasa looked at a bunch of MS patients that had gotten up to 18 doses of gadolinium contrast and looked at expanded disability scale and tried to look at whether there was any progression that were related to how much gadolinium was apparent in their dentate nucleus, and did not see any association there. Another study by Malio just came out, 9 mean injections in Crohn's patients, and actually did a functional MRI looking at functional connectivity between the cerebellum and the dentate nucleus, and again, can't find anything, I gotta stop doing that, anything pathologic having to do with deposition or retention is a better word, of gadolinium. So I don't know about you, but I'm not seeing a smoking gun here, and the FDA agrees. They have issued various communiques in the last couple of years, but no gadolinium retention adverse health effects identified. They know it goes to the brain and other tissues, more with linear than macrocyclic. That's kind of for another discussion or something we can talk about. They say no restriction is necessary. They do say let's limit it, and I think that's totally reasonable. We don't want to use it where we don't need to or more often than we need to. They've mandated more research and a patient medication guide, which probably just confuses patients more than anything. So my opponent over there did mention the Semelka case paper and the gadolinium deposition disease. This really wasn't a scientific study. It was more of an observational study of 42 subjects that had really very vague symptoms. Could they be related to their gadolinium? Could there be some small cohort of patients that end up with some pain or some funny syndrome? Absolutely. That's part of the unknown risk here, right? But this has come to prominence. We have this Chuck Norris kung fu guy who put a $10 million lawsuit out on behalf of his wife, who he claims has had some of these type effects after her MRIs. But these are very nonspecific symptoms that often these patients have for the reason why they're getting their MRI, right? And unfortunately, we can just hop online and you can find ads like this. Are you eligible for a gadolinium lawsuit? Do you have bone or joint pain? Yeah. Skin thickening or discoloration? I got some of that too. Pins and needles, itching or burning pain, brain fog, memory impairment? Definitely getting that. I think it's from the one gadolinium dose that I had one time in my life for a research study. Where this is leading is really to what I call the perceived risk, which is often way greater than real risk. Our odds of dying in an automobile accident in our lifetime, at least in the U.S., are better than 1 in 100. Your odds of dying in an airplane accident are 1 in, getting close to 10,000, 73 times less. Yet many people are very afraid of flying because they think they're going to die. Not me, I fly airplanes all the time, but how many of us won't get in a car? So this is kind of the perceived risk thing, and I think it's really similar with gadolinium retention. I won't say there is no risk to gadolinium, but we've given 450 million doses. It helps us diagnose, treat, manage, and save the lives of many patients as radiologists, where there really isn't another test that is as good. The public perception, however, is that this stuff is dangerous, and we're starting to get patients that are refusing. And if I'm trying to rule out hepatocellular carcinoma in a patient with chronic cirrhosis and they won't let me give them gadolinium, I can't help them. I mean, they can go to CT. It's not as good of a test. It just isn't. So I think it's vastly overblown. The risks of withholding gadolinium for patients is really, when it's needed, is really something that is measurable risk. So a couple final thoughts. I think we really need to stick to science here. We need to be investigating this more. We need to avoid hysteria. We need to educate our patients and the public. But we do need to use gadolinium wisely. And by that, I kind of think of it as being like radiation. I mean, no one's going to say, oh, radiation's too dangerous, stop doing CT scans. But they are going to say, let's try to keep the dose as low as we can. There's a principle in radiology called LARA, you've probably all heard of, as low as reasonably achievable, which means we try to minimize the dose to do the job that needs to be done. Dosing issues, I think, are important, and I think there are societies and other places, and maybe we can get involved in this as well, where we do talk about places where we can be doing non-contrast MRA or multiple sclerosis patients where we don't start them at age 15 getting 3 contrast MRs a year for life. We can kind of tone that back to lesser studies, and particularly the young. So I think a lot of research is kind of important. So I'm not worried.